You are starting? Okay. So I think we have everything to start today. Thanks everybody for joining us. This is a great pleasure for all the team to have Dr. Mercedes Serrano today with us to speak about stroke-like episodes and epilepsy in CDG. And how it will work, the virtual coffee, the team will passing the slides. In the meantime, Mercedes will presenting. Sent to we think it will correspond to your wishes, let's say like that. After the frequent questions and answers, we will have a part where we will not record, but we will have a moment for exchange among all of us, because that was what you requested us in the last virtual coffee. So it will be at the in the last 20 minutes, 25 minutes, where we will all have the occasion to share our experiences with stroke-likes or with epilepsy in CDG. And Professor Iaken and Dr. Mercedes, they will stay with us, well, for listening our experiences, because it's very rich for them as well. So I give the floor to Merche. Thanks, Merche, again, and the virtual floor is yours.
Thank you so much, Vanessa. Can you all hear me? Yes, it's a pleasure for me, and it's a pleasure particularly in these difficult times when we are missing so much, seeing each other, seeing the patients as frequent as we normally do. So I'm glad to be here with you today. And however, we are going to talk about two difficult things, difficult to understand, not only for patients, but also for physicians. I mean, stroke-like episodes are not fully understood, so it will be difficult to clarify, but I will try to do it with my best. And I will begin with epilepsy, which I think is a little bit more easy. So we are going, next please, we are going to talk about epilepsy. Next. Okay, thank you. Seizures, what is seizures, what is epilepsy, and what are the EEGs, or also called electroencephalograms? We go for the next. Okay, what's a seizure? What's an epileptic seizure? It's like a simultaneous, exaggerated, abnormal discharge of activity of a group of neurons all together. You can see here an EEG, and I know we are not in EEG, but you can see here that something is happening all together at the same time. So this is a discharge. This is many neurons all together synchronized, making the same activity. And the fact is that if I have some group of neurons doing this activity, they are going to interfere with the other neurons that cannot work properly. So this is important, because if we have this kind of activity, we have a child that is not going to learn properly, pay attention properly, or behavior properly. Next, please. We can have different kinds of epilepsy or epileptic seizures. We can have focal seizures. This is only a group of neurons is making this activity. And sometimes if we have a focal seizure, the patient is perceiving everything, is not losing conscience. So he may have some movement of the hands or in the face. But when this activity propages, and it's like making a contagious with all the neurons in the brain, what we have is a generalized seizure. And this is when the patient lost consciousness and has an amnesia of what is happening. Okay, so we have focal seizures and generalized seizures. Next, please. In both groups, we can have different kind of seizures in terms of what we see from outside. We can see convulsive movements, muscle stiffness, which is rigidity, or hypotonia, like loss of muscle tone, tremor, myoclonus, or just jerks. In other cases, which are more difficult to diagnose, it's only a movement of a stair, fixing a stair somewhere, like looking with an empty side without causing convulsive movements, or sometimes they are subtle, like just chewing movements or moving one hand, and that's all. These are difficult to diagnose because clinically they are not claiming our attention, so you have to look for them if you want to diagnose them. Next, please. So it's not the same about epilepsy. It's not the same talking about epilepsy that talking about a seizure. We talk about epilepsy when the brain, for one reason or another, you have a disease, you have a traumatism, has a predisposition to have repetitive seizures. So this is really important. Next, please. That epileptic seizure is different than epilepsy. In fact, 15–20% of the people with normal development, with no neurological problems, may have an epileptic seizure in their life, maybe because of traumatism, hypoglycemia, or any other stressful conditions. Next. Why CDG associate epilepsy? Well, the epilepsy is like a symptom, it's like the pain. There are multiple causes that will lead to pain. There are multiple causes that happen to our brain that are going to lead to an epilepsy. One of the first one is the interferences with the energy, getting the energy. And this is why the mitochondrial dysfunctions are very related to epilepsy. Another thing is that the normal relationship between the neurons that are going to create this activity and the astrocytes, that are the cells that take care of the neurons, this coordination is not working properly in the case of some CDGs, and this is going to lead to an excitatory tone of the neurons and finally have this activity that is not normal. And another reason that probably may be underlying is because we have some neurotransmitters. Neurotransmitters are little molecules that communicate one neurons with the others. If these neurotransmitters are excitatory, what they cause is an increase of activity in the next neuron. When they are inhibitory, what they cause is an inhibition of the activity in the next neuron. If we have a problem where the excitatory neurotransmitters are growing up and the inhibitory neurotransmitters are going down, we have this facility, this predisposition to have seizures. And sometimes what we do with anti-epileptic drugs is exactly that thing, increasing the inhibitory tone of the neurons and these kind of neurotransmitters. So this disbalance may be the underlying reason for having epilepsy in many cases. Next one. Okay, how are we going to diagnose, how many CDGs have been related to have this epilepsy? There are mainly two groups. In the first group, next please. In the first group, we have the epilepsy like the main determining for the prognosis, like some CDGs where the epilepsy is refractory and is intractable, and sometimes we have to perform invasive treatments despite the pharmacological therapies. And this is the group of ALD, many ALD, or the Golgi complex. Many Golgi complex has also these refractory epilepsies, but also the PID, the group of PID also are related to refractory epilepsy. But normally, in the case of PMM2, which is the most frequent one, as you know, PMM2 is normally not severe epilepsy, sometimes transitory, and sometimes we can manage it with one drug, maybe two drugs, but the prognosis is good. Next one. Next one. Sorry. That was a mistake. Yeah. Okay. Talking about diagnosis, how are we going to diagnose? The main thing in the diagnosis is listening to parents and watching the videos that if they have been able to record them with the mobile phone, to see the type of seizures and to see if there are personal antecedents, family history. So the clinical interview, what we call anamnesis, is really, really important. But we also have another technique, which is the EEG, the electrocephalogram. The electrocephalogram is informing us about how is the activity in the brain, in the cortical surfaces of the brain. And this is why we put the electrodes near the cortical surface of the brain in the head with these different cables and a cap and so on. We need to stress the brain. To see a good electroencephalogram, we need to put the brain under stress, metabolic stress, sleep. So we normally demand the patients 3 efforts. The first one, next please, is please bring the baby very tired, because these changes between being awake and asleep are really dangerous for the seizures, but also the awakening in the morning. So we need to see how he's going to fall asleep and how he's awakening. The hyperventilation, which is breathing quickly, sometimes is difficult with some patients, but is also really informative, particularly in the absence seizure, which are really difficult to diagnose because they don't move anything. They just stare, fixing the sides, and that's on. And the last one is the intermittent light stimulation, which is giving lights on different frequencies and see if the EEG is changing or not with these frequencies. So when we have the clinical interview and we have the EEG, we will get the type of seizures. They are focal, they are clonic, they are absences. And also we will have what kind of a line is appearing in the EEG. And with this information, when we combine this information, we are going to make a choice of a personalized anti-epileptic drug for that children. Sometimes in some diseases, there is literature saying for this disease, the best treatment is that one or another one. This is not the case in CDG. We normally use the most used drug, that valproic acid, levetiracetam, and having this into consideration, the type of seizures, the children, if he's taking other drugs, and the type of paroxysmal activity, this line that we see in the EEG is enough. So, can epilepsy start at any time? That was a question that really concerned some of the families. Well, in general terms, yes, seizures can occur at any time during childhood, adulthood, maybe depending on the CDG. In those that refractory epilepsies, normally the rule, they will appear when they are infants or during the first days of life. But it's really high variable between the patients. But something important is that younger brain is less inhibited. So we normally see these febrile seizures, which are normally in the neurotypic population. These febrile seizures, they normally are presented in the little ones, in the infants, and this is because infancy is an age where our brain has a very excitatory tone. So normally with the age, the epilepsy will improve. And it's important also to say that the refractory epilepsy that we have seen in some CDGs has really severe consequences in neurodevelopment. And this is important because we need to be really aggressive with the therapy, maybe 2 or 3 anti-epileptic drugs at the same time. Okay, another question that we can reflect about is that if we perform an EEG to ourselves, we may have some of these paroxysmal findings that we find also in epileptic children. So it is important that we are not treating EEGs, we are treating patients. So if I have a patient that has not seizure, there is no neurodevelopmental problems, it's slow but it's progressing. If I perform an EEG and I find these paroxysmal findings, probably there's no need to treat. So we need to be very conservative. Why? Because the anti-epileptic drugs are going to inhibit our neurons, so they have also side effects. Okay, in the EEG, we have these paroxysmal findings sometimes because maybe they are not, if we have not epilepsy, but there is another important part that is the background chase. The background chase is informing us about how is maturing the central nervous system. With the age or rhythms, in the EEG are changing and are going more faster. So sometimes if we are performing an EEG in a patient neurodevelopmentally delayed, we are going to see a delayed background compared to the age. And this is absolutely normal, is what we expect because the development is retarded, okay? Next one, and I think the next one too. Next. And the next. Okay. So this is about epilepsy. It has been too quick, but we can go with the questions back again if you need any other explanation. And let's go with the stroke-like. Next. What's an stroke-like? An stroke-like is a situation that, can you pass the next, please? An stroke-like is a situation that is resembling, that is remembering as a stroke, an ischemic stroke. That is normally happening in the elder people, sometimes with hypertension, cholesterol, and any other risk of factor of risk. And what we have here is a child having the same or pretty similar clinical symptoms. Sometimes is a can you put the previous one, Rita or Carlota?
So it's Sandra that has the control.
Okay, Sandra has the control.
Can you do it?
Sandra is the captain. The previous one, yes. Yeah, that one.
Yeah.
Okay. Yeah, it's just to make you pay attention in three things. That is three characteristics that are the same for patients, but also for physicians and families. A stroke-like is unexpected. We have no idea when they are going to happen, and this is very difficult to prevent them. They are very stressful. They are acute, and nobody knows what to do. So it's stressful for everyone, and they are probably underdiagnosed. And this is why you have to be really imperative. Maybe if you go to the physician and he doesn't know, she doesn't know about this clinical picture of a stroke-like, you have to illustrate them and show them that this can be a stroke-like, because it is really important. The definition, well, there's a lack of definitions in the literature, so probably this is why we are not aware, or not as aware as we should be, the physicians. Next one. We proposed a definition 2 or 3 years ago that is something like an acute event. So it's something that is acute, that is presenting abruptly, consisting of sudden onset of focal neurological deficit. Focal neurological deficits means I can move one hand, I can move one leg, or I can speak, or I can't swallow. This is a focality. This is a focal neurological deficit. But it also associates irritability and decrease of consciousness. And this is something different to a typical stroke. Normally in a stroke, you may have a headache and you may have this focal neurological deficit, but probably not this irritability, somnolence, and so on. It may associate with seizures, sometimes in the course, not at the beginning, with headache and other transient symptoms. And the thing here, the important thing here, is the absence of another diagnosis. So if we have the idea that maybe is a meningitis, or maybe is an hypoglycemia, we need to rule out the other causes, because the other causes are all treatable. And the stroke-like is not essentially treatable. So this is very important in the absence of another diagnosis. In our particular case of PMM2 patients, what we need to rule out is a real stroke or a real thrombosis, because as you know, there is a normal coagulation in this group of patients. Next one. So this is some of the clinical symptoms that you may have, and you need to be alert to increase your possibility or awareness about a stroke. Like the irritability or decreased consciousness is something that they are lethargic, but they cannot fall asleep. Is a very like a difficult situation to control because they are uncomfortable and they are suffering pain, but they are not able to say what they need. And then when this phase is finishing, they are going to show this focal deficit. Maybe the most frequent one is one limb. They cannot move one hand, or they cannot move half of the body. Next one. This is a study that we present some, I think 2 years ago. This is 9 episodes from 7 patients, and I will go with you through the table to present the main clinical features of these 9 stroke-like events. Next one. If you see here, there was a trigger, that is the head trauma. Sometimes there was a mild head trauma, but also the infectious disease like the enterovirus or maybe the influenza virus. But they were the 2 main triggering factors in our series. The next one. There is also something very interesting, that is we have a free symptom period of time that sometimes is 24 hours. So it's really difficult sometimes, if you have no the suspicion, to correlate the head trauma of the day before, sometimes a mild head trauma, with the event of a stroke-like situation. Of course, in the cases of infection, it's really difficult to state this free symptom period, but when there is a head trauma, it's easier. And as you see here, there will be 2 hours to 24 hours of normal life, and it's like the mechanism in the brain is advancing until you have the stroke-like. The next one. Another important thing is that we are going to have an increase in the temperature. And if you see here, we didn't write down fever because we really believe that this is not fever. Fever is the answer to an infection or an inflammatory process where you will have some substances in our body that are going to increase the temperature. What we think is that the center of temperature control, which is in the neurons, which is in the hypothalamus, is going to be affected by the stroke-like event. And this is why we call it hyperthermia, because it's a neurological process. It's a bad regulation of temperature because it's a neurological disease, but not of a context of infection or inflammatory. Because in the next column, as you can see here, we have some of these reactive factors that we are measuring to detect the inflammation of and the infections, and they are normal. They are abnormal in the cases of influenza virus because we have an infection context. But in the case of this head trauma, we have this increase in body temperature, but the normal measurements that we normally use to detect infections and inflammations. Next one. Really, really important, particularly for families. There is a total recovery in almost all the cases, maybe more rapid, maybe more slow, but they recover. Many of them, as you can see here, in some hours, 48, 7 hours, 36 hours. So this is really important to maintain the calm and to be positive during the stroke-like episodes. Next one. Well, what we normally find in another studies like the EEG, normally the EEGs will be abnormal in case we have seizures. And the seizures, as I told you, are not in the first hours. They are normally in the second or in the third phase of the stroke. Like this is one of the most severe cases that we have lived, and this is one patient that remained with a left side hemiparesis during some weeks. And as you can see here, you can perceive in this, you cannot see me, my pointer. Yeah, I was marking, but you can't see it. Yeah, in the lines below, can you see some slow waves in the EEG, in the square A, in the lines below, you can see like slow waves. This is the only thing that we can be able to find during a stroke like. And if you go down in the image in the C, in the square C, if you see there is no symmetry in the region below, which is the occipital region, one is like swelling. This is what we call vasogenic edema, but we are not going to see these territories of the arteries which are thrombosed, or we are not going to see hemorrhages like we see in a stroke, in real stroke. And this is called vasogenic edema, and it's different, next please, of the cytothoracic edema. That is what we see in ischemia and in a real infarction. The ischemia and the real infarction is going to kill the neurons, but the vasogenic edema maybe is reversible. So we are going to recover these neurons. Regarding the treatment, it's difficult to standardize the treatment because there are no clinical assays, but we are sure that we need to check the coagulation to evaluate if we may need to treat with antiaggregants or anticoagulation. As the single change that we find is electrical activity, I think that anti-epileptic drugs are useful during those days, so maybe we can stop them after the stroke-like episode, and of course treat the hyperthermia, because the hyperthermia is really a metabolic stress that can perpetuate the stroke-like, but also can make the child being devastating, really fatigued, and really tired. Okay, next one. I want to share with you the last stroke-like episode that I lived in the hospital. It was an 11-year-old, no antecedents, no another stroke-like episodes before. And she presented with fever up to 39 degrees, which is really high. And it was interpreted like a viral infectious process. But after some hours, she was still with this hyperthermia, and she showed a left side headache, really left side, really defined in the left side, somnolence, right arm monoparesis. This is she couldn't move the right arm, and particular difficulties in denomination. And this is because in the left side we normally have the dominant cortical area for speech, and she was unable to find the words she wanted to say. Next. So we have the suspicion of an stroke-like because she's a girl, she has a PMM2, and everything was really compatible with an stroke-like episode. But as she presented these febrile neurological symptoms, it's mandatory, it's obligatory to rule out any treatable disorder like a meningitis performing and lumbar tap, or a cranial tomography and magnetic resonance imaging. As you can see here, the magnetic resonance was absolutely normal. You can see the cerebellum, which is of course atrophic, and this is something really expected because she is a PMM2 CDG patient, but anything else. The coagulation tests were normal, and 3 hours later, the patient was improving with the normalization of the temperature, and she increased the left arm strength. But I want to remark that during the next 24 hours, there was a fluctuation and an oscillation of the symptoms that has been reported later by another patient too. That is that every time that the headache in the left side was increasing, she has these difficulties to move the left hand and to talk. So it's like an electric event, it's like a seizure. And I think, next one please, that if there is something typical to detect a stroke-like episode, is a triad, is a combination of migraine, focal deficits, and this refractory hyperpyresia, because we normally treat the fever with analgesics that are anti-inflammatory, and they are not going to work in the case of hyperthermia due to neurological causes. And sometimes treating with neuroleptics or anti-epileptics, we are going to limit this fever, that is not a fever, better than with anti-inflammatory drugs. So this triad is really typical, but it is not specific. And this is the difficult thing here, that sometimes physicians may need to rule out another very severe treatable causes until they get the confidence that they are in front of a stroke-like episode. The next one. So my personal view as a clinician here, when I have a patient or I have a call from a colleague in the emergency room, is that we really need urgently to detect positively with positive things the episodes in this group of patients at risk, because now the diagnosis is based on the ruling out of other acute neurological processes, and this is really time consuming and is really costly, economically cost, of course, and it's also increasing the suffering of the family that is going under several procedures. But well, unfortunately, at the present time, we are not at that point, and we still need to perform these invasive studies like the lumbar tap and the neuroimaging. And the thing is that sometimes it has been described that the sedation, the anesthesia that we need to perform the MRI, the magnetic resonance, is increasing also the risk of another stroke-like episode. So this is really difficult to ponderate. Where is the risk? Where is the security? It's a difficult thing. So at the end, what we need to do is study more and recruit more of these different episodes for many patients to know more and to conclude with positive things, something that I can find in the patient to be sure that this is a stroke-like episode, not needing to rule out any other thing. Next one. Yeah, and just to finish some of our hypotheses about why the stroke-like episodes occur, and our hypothesis was created because stroke-like episodes are really similar to familial hemiplegic migraine, which is a clinical phenomenon that is related to some channelopathies. The channels are like doors, like gates that are in the membranes that are opening or closing. Calcium is entering or going neurons, and in this pathology, which is a calcium channel, is a gate of calcium in the neurons. They have the same problem. In this I put here, profound encephalopathy with complete recovery, they report 3 children that have a very mild cranial traumatism, and they present the same clinical picture. And this is, they have fever, they have this, hello.
Hi, so sorry. So Sandra, please don't allow. Yes, this is technology. This is technology. We have to take care of this for the next time to make sure that the host and co-host are the ones with the power. So you can continue.
No, these are the fun things of direct. Yeah, so there were 3 children that suffered the same as a stroke-like episode in our PMM2 patients. And this is why we began to think, what is the connection? Why are they so similar? The next one. And next one, please. Okay, here we have this channel. This is the calcium channel, and we can see here the Purkinje cell. Purkinje cells are the main neuron in the cerebellum. And a channel, as I said, is like a gate. So this calcium channel is allowing the calcium going in and going out. And this calcium channel, they are normally highly glycosylated. The next one, please. You will see the glycosylation antenna here. Okay, so channels are highly glycosylated, and as you know, the glycosylation is really relevant for the function of the proteins. So we will begin to interrogate about how would be the possibility of shorting this or removing these glycan antennas, and what will happen with the channel activity. Next one. So we perform with some experiments. Next one. We perform some experiments with Dr. Fernandez, which works here in Barcelona and is an expert in CACNA1A. Okay, and what we did is put in the cells, this membrane with calcium channels in tunicamycin. Next one. And tunicamycin is going to remove this glycan antenna, like this is the case of a PMM2 patient that has not the correct glycosylation in this calcium channel. And what we find is that the channel remains, the next one, remains a longer time open. And this is exactly the same that happened with the patients with familial hemiplegic migraine that I saw you before. These 3 children that have the clinical picture pretty similar to the stroke-like episodes. And this is why we begin to think that this channel has something to do with the stroke-like episodes too, that the channel is too open. This is the problem. Next one. Okay, and let's talk about the triggers, because it's intriguing why the head trauma is going to cause, next one, is going to cause this stroke-like episode. Sometimes it's a virus, and the virus is a trigger for every metabolic disease because it's creating a metabolic stress. And if we are working in the limits, almost in the threshold, when we have a metabolic stress, we are beyond the threshold and everything is going down in metabolic diseases. But in this case, next one, what about the head trauma? This is really intriguing us. So with this group of Dr. Fernandez in Pompeu Fabra, which is a very important university here in Barcelona, we are making some hypotheses that he is already exploring. Next one. And one of the hypotheses is that we, in our cells, also in our neurons, we have mechanoreceptors, which are called piezo-1 and piezo-2. And they are probably abnormally glycosylated. And if they are abnormally glycosylated, they perceive the pressure or the vibrations, they perceive them differently. And probably they are not protecting the cell as well as if they were appropriately glycosylated. This is one of the hypotheses that he is working on. He's making the mutation where this antenna has to be in these mechanoreceptors. And the other possibility is also, next one, is something to do with the glycocalyx. The glycocalyx is like all the structure that is also maintaining the cell with the normal volume and structure that probably is under glycosylated. Next one, please. Is under glycosylated and probably has something to do also with this, how to say, buffer possibilities when you have a cranial traumatism. And so it can be a trigger of these abnormalities in the stroke-like. But there's another question still open. That is, why if I have the stroke-like and I have this abnormal mechanoreception, abnormal glycocalyx, why I need to happen to pass some hours of normality until I have the symptoms? And this is because probably the mechanism that is going to be activated has something to do with gene regulation, gene expression, or who knows. But as you see here, we have many questions and no so many answers. And well, it's something still open, but really, really interesting. And I'm really committed to keep on studying the stroke likes and know more. Thank you so much.
Thanks, Merche. This is a fantastic presentation. I could see already in the chat, people are congratulating you. We already have people that want to translate it into Italian. So you see, this is powerful. And I think now I have to give the floor first to the team if they want to add something, or because the pool is rather at the end, right? So we should now have the questions and answers. Is that correct? Carlotta, yes?
Yes, yes.
Yes. So I take care of the chat, but I would invite the participants to unmute and to start ask questions and take advantage of having Merche with us. So we have Louise, Raymond.
Hi.
Hi, Louise.
I'm Louise from Denmark. I'm the mother of Matthias, who's almost 26 with PMM, what's it called? 2? CDG 1A. He started having seizures again after, well, he's been on medication for 15 years, but suddenly after 10 years, the seizures came back. We tried to decrease the medicine. The seizures came, so we went back to his normal medicine, but it's not working anymore. So we have to increase the Keppra even more. And something else we've seen is now that he has some low metabolism. And can that cause a seizure? Because now we see when he's hospitalized with a seizure, his blood works say that his metabolism is low. Is it low because of the seizure, or has he had a seizure because of low metabolism? And nobody in Denmark knows anything.
But thank you, Luis. But now Matthias is doing good with this increase in the doses of levetiracetam. He's doing good.
So far, yes.
Okay.
Yeah.
Because sometimes you treat a patient with he's a child or he's an infant, and then he grows up and everything changes because these changes in the excitatory and inhibitory tone in the brain, and also the adolescence. So
yes.
it's difficult. Sometimes it's not the biochemical mechanism, but the age of the patient, which is going to determine the efficiency or not. And in my experience, some of the children that I follow with metabolic diseases or other kind of epilepsies with levetiracetam, what I see is that they have irritability with the Keppra, with the levetiracetam. So when you increase too much the dose, they are like always negative and angry. Yeah,
he's a monster.
Because now we have another solution, which is brivaracetam. It's like the cousin of levetiracetam that is also working properly, and sometimes they are happier, which is really important. I mean, it's important because we have patients with behavioral disturbances, so we don't want them also angry.
No.
Yeah,
we tried the Briviact. We tried it, but his dosage was too high.
Okay.
So for the anger, we take B6.
B6.
Yeah.
And is it working more or less?
Yes, I think so. B6 and CBD.
Okay.
Yeah.
Yeah. In any case, levetiracetam is a great drug.
Yes.
It's not altering at all the intellectual quotient, and so it's a very good drug. Yeah.
Yes.
Even better than the valproate that has these cognitive effects, and we don't really want for them.
No. We're very happy with the Keppra, but now the question is with the metabolism. It's the I wrote it down. It's his thyrotropine goes up and the thyroxine T4 goes down. Do you know that this can cause a seizure?
I don't think so. What we normally see in this, maybe Dr. Jacken can also help with the answer, because he's an expert in these hormones. But we don't used to see these hormonal changes causing epilepsy, more causing diarrhea, loss of weight, or tremor, maybe tremor, but not actually epilepsy.
Okay. Thank you.
You're welcome.
Jack, do you want to add something?
Right. Most patients with PMM2 CDG have a relatively loud total T4, but the free T4 is normal. So I don't think this has nothing to do with epilepsy also.
Okay, thank you.
It is I would say, a sign of PMM2 CDG.
Okay.
Okay. Louise, you can reach me out if you want.
Thanks.
For some more help in this at this level.
Thanks so much.
So maybe I'm going to look on the chat because we have Stacy Vogel, but maybe Stacy, do you want yourself to do directly the question or do you want me to read? I don't know if you are in a condition to speak, Stacy.
I just had to find the button, sorry.
So Stacy, you may want to highlight which CDG type we are speaking.
Sure.
That's important. And then you raise the question yourself directly, the question you had in the chat.
Okay. We were diagnosed not that long ago, even though we're at age 19, with CDG 1C, although Dr. Morava has just recently taken more blood and some skin cells she found at Mayo from when my daughter was tiny to explore if there are other things in addition. But for right now, she proved with some lab tests that we have glycosylation defects, and it seems to be the 1C. Tana has had intractable epilepsy her entire 19 years. The seizures began when she was 4 months, or at least we noticed them at that point, the same week as we saw the neurologist, of course. Fast forward to last week, she's been sliding, we'll say, with seizures increasing. And as someone just mentioned with their older child, it feels like every few years, and you know, whatever that is for each age group, but when she was younger, it occurred more often. Now that she's older, maybe every 3 to 5 years, it feels like we have to go kind of change her recipe or cocktail of the different medications she's on. She has been on up to 7 seizure meds at one time a few years ago, which is kind of insane. I gotta say, you cannot tell what is doing what for which seizure at that point. And you send seizures underground, meaning they're so sedated you can't tell if they are or aren't seizuring because they're so somnolent. You just can't tell. But last week we were admitted for this same pattern of increasing seizures. And the presentation that we were concerned with were these staring episodes, which you've described in your presentation. Her eyes deviate upwards and start with up, down, and then they get stuck up. And she seems to be unresponsive. You can't break her out of them. You can't tap her face or talk to her. She can't answer you in her very limited communication styles. And we have, for over 10 years, treated those as seizure status, stuck, and I called it stuck. She's stuck in her stare episodes, and treated her with midazolam injections in her legs because she needed such a high dose. She needed 17 grams. And during the EEGs last week, they determined or believe 4 different neurologists, so it's not just one, believe that they are eye movement disorder, not seizures. And my brain is having a hard time processing that. So anything you can comment on it would be appreciated. I can say that the only thing that breaks these events is either midazolam, like I said, we used to do, or we began using Ativan or lorazepam. And I'm just open to any ideas or thoughts you guys have on eye movements, or if anything else you want to offer. Sorry for that long question.
Yeah.
I think it was helpful.
Thank you, Stacy. This is a really difficult question also for neurologists, because sometimes the eye movements are really difficult to interpret and to find what is below. And sometimes there's a combination. Some of them are upwards, are tonic up gaze deviation, and that's all. And this came from the midbrain near the cerebellum. But sometimes they are also tonic seizures that came from the frontal or from the occipital lobe. And sometimes they are a mixture. So in my hospital, if he would be my patient, what I would do is maybe 1 week registering, 1 week, and try to see what kind of seizures do we have. And sometimes what we do is try to withdraw the drugs and see what happened, and try to count again. Is this real a movement disorder, or is this an epileptic disorder? And I think it would be informative. In this case, it's really complicated to interpret.
Share that they did at least 3 or 4 days of an EEG.
Okay.
Pardon me, we didn't withdraw much. I think everybody's a little nervous about pulling her off meds.
Yeah.
but we added, we dropped, you know, I mean, they were trying to increase and decrease. I mean, within a few days, we tried Vimpat, we ditched it. We came home on zonisamide, we dropped that because that caused other side effects. I'll share with you, she is not able to take Keppra. I don't think we've been on that since she was little. And I hear that you all have found that that's a good drug. I don't know. I think we've been on everything, honest to God, at some point or another. And I feel that your presentation was fascinating because I'm trying to understand the channels, like you were saying.
Yes, in fact, some patients with this CACNA1A, which is this channel, they normally do this tonic up gaze deviation. This is a typical movement of channelopathies. So it's interesting. And another interesting thing is that the family of diazepam, like lorazepam, midazolam, they are working also for these movement disorders. So what are you treating? But in the case that you have these movements, I have some patients that get really angry because they present these movements, but they are conscious. And here the point I think is that one, is he conscious or not? Because if he's not conscious, I would try to think that it's an epilepsy. No, it's an epileptic seizure. I don't know.
That's how I feel, because for 10 years we've had a seizure. Like I said, you can't tap her out of them. You can't break them until you give her a medication. I used to think they were triggered by urine infections because she has a Foley, a suprapubic indwelling, constant concern for UTIs. But I think that's kind of, if it's not a seizure, boy, I got to tell you, it's really hard after 10 years of these are seizures to rethink my process that it isn't. I'll send you or Vanessa or someone just a snippet of the rubber eyes.
Stacy, I was in because I see more. There are more questions in the chat. I strongly invite you. Have my email. Please send it to me, and I organize with the Merche and Professor Yaken. I think we try, and then you are also being with Eva, so so it's also very helpful. I think so. If I look on the chat by order, there is a comment related with stroke likes, but then there is Li Yan, who is saying that currently they are being given ibuprofen and lorazepam at the onset of symptoms of a stroke-like episode. In your opinion, is this the right course of action? Asks Lian. So
well, in fact, lorazepam is mainly used in the States, and we use more midazolam, but it's the same. I mean, it's a wonderful drug for the acute episode, not for the long term. And it's important to remark that it's not going to prevent. So we have no evidences at all in the long term, in the chronic use of anti-epileptic drugs for preventing the stroke-like episodes. But in the case of an acute episode, yes, it's one of the best drugs. And I think there is a paper from Dino Poulos, I think it was 2015 in pediatrics, that they registered 3 patients with the stroke-like episodes, and in the 3 cases they used lorazepam. This is a good drug. In the case of ibuprofen, I don't know, because I don't think there is really an aggregation, a coagulation problem, but if they have indicated, probably they have made some lab tests and the choice is supported, of course.
Thanks, Mercedes. We also have from Fenk a question. So Fenk, we are. It's also PMM2 CDG, your son, right?
No, my son's. It's not sure which subtype they have.
Okay, that's why it's important. That's why I was highlighting. So you do you know which did they indicate more or less the pattern? It's a 1 or type CDG type 2. What do you have?
They think 1C because I have the L6 mutation, but they couldn't find it in my husband, and that's why they're now doing further research.
Okay, so this is important because Frank is mentioning in the chat, our youngest son has had several periods of sleeping for up to 48 hours, just laying down, not eating and drinking, no pain, sometimes a high temperature. He's no verbal, so can't tell how he feels. Could this be a stroke-like episode? Of course, we have this uncertain diagnosis, so that's why I wanted to highlight this to Merche.
Yeah. Well, that's a good question. We have a patient that is now, I think it's 15, and he suffered these kind of episodes every 2 weeks, and he was able to describe what was happening, and he was like feeling really tired with headache, and he needs to sleep, and maybe in 12 hours, 10 hours, he recovers, and that was all. And when we performed this clinical assay with the acetazolamide, which is limiting the stroke-like episodes in the channelopathy, he really improved. And that was the proof, that was the confirmation that were stroke-like episodes. So probably we have the whole clinical picture with this very severe going to emergency rooms, focal deficits, but perhaps we have also these mild stroke-like episodes that are really somnolence, some hyperthermia, several hours, and that's all. And in that case, it's really difficult to identify the trigger. Yeah.
Yeah. Yeah, well, yeah, no triggers up to me because it just happened. He could come out of bed perfectly fine and then lay down, and then it was for hours or 48 hours. When we were on vacation, he would lay on a air bed underneath the trees for hours and hours, days, and then all of a sudden he was back, nothing, as if nothing happened.
Mm-hmm.
So,
Yeah, maybe. Well, in fact, there is no exclusivity of stroke-like in PMM2. There are more CDGs that also are potential of suffering this stroke-like, and probably is also underdiagnosed, I'm sure. Maybe,
And is it the same kind of stroke-like episode as you see in MELAS, the other metabolic disease?
No, in the case of MELAS, it's a mitochondrial disease, and you can see real change in the signal in the MRI, in the resonance. Okay. So you can, it's not respecting the territories of the arteries. So it's not like a normal stroke, but you can see changes in the cells. But it's more a cytotoxic edema more than a vasogenic edema, which is in the case of CDGs.
Okay.
Yeah. Yeah, but sometimes the terms are confusing. Also for clinicians are confusing because we use this bug term like, no, stroke-like, and everything is a stroke-like, no? So it's difficult.
So I'm cautious about the time. So, and I want to ask mainly to Merche and Jaak, if that's fine for you, if we stay until 5:15, because we have 3 more questions. Just to highlight, Fenke, your situation is exactly the same than Stacy. So I will put you two in touch, okay? I will facilitate this. So, Sandro, just to shorter your question in the chat, can you ask directly what is the question? Because I cannot figure out the exact question you are asking in the chat. We cannot listen, Sandro. Sandro? So Sandro maybe he's just left his comment. So we have from Maria Rosaria. Is there something we can do for hypotonia that increases more after seizures? Is a question.
Yeah, the question is really important, because when we have a seizure, particularly a motor seizure, it's like running a marathon. I mean, the effort your muscles do is really hard. So then you have this, you need a rest. And there is also a phenomena that is called the paralysis of thought, which is like the neurons need that rest too. And they are under a very low activity, and your muscles have no tone. So this is just a question of time, of recovering these neurons, they whole activity.
Okay. So another question from Jenny. Jenny, maybe I could see you before. Maybe you want directly to do the question. You can, yeah, please.
Yes, my daughter has improved slightly, but her seizures were worse when she was sort of 8 or 9 years old. And after bad tonic-clonics, we would see this paralysis in her one side of her body and the left side of her face. And you haven't mentioned face, but, you know, there was a definite paralysis on the left side. You know, she could frown and it would be smooth one side and very frowning the other side, and the whole of the left side of her face would drop. We're not getting the tonic-clonic seizures now, but we do still see this face drop, and it's not really acknowledged as epileptic by our neurologist. I just wondered if that facial issue was something that you see in other children.
Knowing that she is ALG 11.
She's 15 now.
15 years old, and she is ALG 11 CDG.
Sorry, yes, ALG 11.
Yes.
Yes.
Mm-hmm.
Yeah, it's the same as I think it was Stacy were talking about abnormal movements. Sometimes we have myokemias, which are contractures of the muscles that are not dependent on electrical activity, because the cortical region that is mixing this one side and another side in the face is really difficult to. It's not coherent with the cortical regions we know. So. Yeah, one possibility is that one, is that we are controlling one side and the anti-epileptic drug is changing perhaps the epilepsy, because when we treat the epilepsy, we are like camouflaging the activity and seizures may change. But the other possibility is having this myokemia or dyskinesia or some of these movement disorders that sometimes don't have a correlate in the electroclinical EEG, but they still persist, and they can be also very uncomfortable. I mean, they also need to be treated. And sometimes the drugs we need to myokemia and other movement disorders are the same that we also use for epilepsy. And sometimes in the case of these dyskinesias, we use carbamazepine, which is also a good drug for some kind of epilepsy, like focal seizures or some typical graph elements. So yes, this differential diagnosis is difficult sometimes. The best thing is to have to register one of these episodes when he's under EEG registering. That would be great.
We haven't managed to catch one yet.
It's difficult. Yeah.
Yes.
There are many families that do the videos, right? Because now with the phones and so on, the videos can be very useful.
Yeah, I can catch it on video, but we haven't managed to catch it on EEG because they're so few and far between. But thank you, that's helpful.
You're welcome, Jenny.
Thanks, Jenny. A question, so I think I figured out what Sandro wants to transmit us. He's the father to Benedetta, which is SLC 3582 CDG. She's now 9 years old. She's on Depakine, galactose and CBD oil, 15 droplets a day. So, and the question from Sandro is just to know if there are any alternatives besides the known anti-epileptic drugs. I hope I transmitted correctly. I feel the responsibility.
Yeah, so Sandro is asking about any other alternative, no anti-epileptic drugs, right?
So it's a pity he cannot communicate orally. Because he describes, I can ask the team if they can help me here because it's a long paragraph. And yeah, so I cannot be of help here, I think. Can you ask again? Because maybe you can in the meantime write, Merche, please. Can you ask again?
Yeah. The question was about any other intervention different than anti-epileptic drugs right?
Yes.
You're also talking about CBD, which is cannabidiol. And as
Yes.
you know, we don't know if we can consider the cannabidiol as an anti-epileptic drug. In the case of the EMA, European Medical Agency, is only accepted for Dravet syndrome, which is a genetically determined syndrome, and this kind of very severe epilepsies like West syndrome and Lennox-Gastaut syndrome. So in that cases, there is a clear regulatory and normative of production and everything for cannabidiol. But in the other cases, which is like a natural product, I don't know if it can be considered an anti-epileptic drug, but I see that many patients use them, right? Maybe more in the States than in Europe. And then we have a part of anti-epileptic drugs for severe and refractory epilepsies. We have ketogenic diets also that sometimes is working, okay. We have also vagus nerve stimulation, which is an electrical device that is going to stimulate your vagus nerves and inhibits your neurons. And then we have the surgery. But the surgery is only used in those cases where a cortical region of your brain is not working properly because it's malformated. And this is only happening in oglycosylation defects, maybe, but it's not really prevalent in other CDGs. So it's not a possibility in CDGs. But the vagus nerve stimulation and the ketogenic diet, I know that there are some examples in CDG.
So we have to reach the end of these questions and answers. I have to say that it's a topic that is of great importance, Merche, because many families continue to go to the emergency hospital and they continue confronting doctors, that families say to the doctors that it is a stroke-like, and the doctors, because they don't know CDG at all, it become a fight sometimes at this level. So explaining, I think this is one of the projects we want to maybe do together in collaboration with you and other experts and families, is how to facilitate this communication to the medical doctors, right? And because then the families insist on, you know, I have here the guidelines, you have to do this or this, and it's very hard. So this is a topic I have here for us to work together. We are finishing the recording. Please